Welcome to CEVAW Conversations. I'm Sian Human. We're releasing the episode early this month because it's December and everyone deserves a Christmas break. This is a conversation with some of our CEVAW researchers working on substance use coercion in relation to domestic and family violence, along with some of our practitioner partners who work in child and family services.
My name's Monique Yeoman. My role is General Manager of Child, Youth and Family Services at Kids First Australia in Victoria.
Hi, I'm Emma Shaw. I'm Clinical Manager of Child, Youth and Families at Odyssey Victoria.
Hello everybody, I'm Cathy Humphreys and I'm an Honorary Professor in the Department of Social Work at University of Melbourne and a Chief Investigator on the CEVAW program.
Hi everybody, I'm Van Callaly. I'm a Research Fellow at CEVAW and an Associate Lecturer at the University of Melbourne and a PhD candidate.
So one of our opening context-setting questions was if we could start with a clear, accessible explanation of what substance use coercion actually means.
It's when the use of drug and alcohol is leveraged to extend abuse and violence. So this could either be the victim survivor's substance use or when a person using violence is also using substances as well.
So I always think of it as part of coercive control. It's a sub-part of coercive control, which is how are the substances being used as part of the tactics of violence and abuse.
Would you be able to share an example that maybe illustrates what substance use coercion looks like in a family's everyday life and what makes this sort of situation particularly challenging for families to navigate?
I'll maybe share an example of a family that we've intersected with at Kids First over the last few months, where we had a father who was referred into our Caring Dads program, and what we came to understand was that he had been named through the safety plan for mum who was experiencing mental health challenges. He was named as the safe person to administer her medication. And what that then looked like was that he would either withhold or he would administer her medication, and this led to an overdose. So she then overdosed, ended up in a mental health facility again, and the ramifications of that were that her children were then left with the person using violence, and that was actually something that was approved, I guess, by the state in terms of child protection at the time. So really complex because she did experience mental health challenges, but his withholding and then administering medication and really using his power to administer that medication and create a situation for her where her children then were at risk is a real challenging dynamic.
And I think that demonstrates not only substance use coercion, but mental health exploitation as well, and how they're often not mutually exclusive. I think this is a really important case for us to consider, particularly when persons who are using violence are held responsible for administering medication, but also through that process, as you've already said, he was withholding that medication. And so there's concerns there with her tolerance and then the subsequent overdose, which she was held responsible for.
Mm. So the situations can be really complex, and I'm sure they're all a little bit different. Cathy, what does the evidence tell us about how common these sorts of patterns are?
The clearest pattern that we have in relation to violence against women is the gendered pattern. That in fact, whichever survey you look at, of our big prevalence surveys, both internationally and in Australia, it's either 1 in 6 women and 1 in 18 men, or 1 in 4 women and 1 in 8 men, or 30% of women worldwide. So that depends on how it's measured, but the pattern is really clear. Wherever there is the use of substances, it doesn't always, or even most of the time, lead to violence and abuse. But we are talking about how it is used in the context of domestic and family violence. And so whenever you look at another very strong pattern, this other strong pattern is that over 30 or 40 years of research shows that where you have different forms of alcohol and other drugs being used, that you have an increase in the severity, the impact and the frequency of violence. So in fact, severity counts. And maybe we'll give you a little bit more detail from the data about where we're seeing that data and the severity.
One of the most recent studies that we've come across is by Mayshak and their team in 2022, which they published, which found that Australian states and territories, when domestic and family violence was reported to police, roughly 24% to 54% was classified as alcohol related. And when they were able to analyse the data between offenders and victim survivors, they often found that it was offenders who were more likely to be using alcohol. And when those circumstances were happening within a family dynamic, the physical injury rates for a victim survivor doubled or tripled in some states and territories. So we see here really clearly that there's more intense severity of violence. These acts of family violence often involved life-threatening injuries, physical injuries that led to hospitalization. So that pattern is quite clear, and I think that's something we can all agree on, looking at the evidence base, that drug and alcohol use can increase that frequency, overall impact and severity of domestic and family violence.
Maybe the other really powerful piece of data comes from the analysis of the Australian death reviews, where they looked at domestic homicides from 2010 to 2018, 240 murders of women, of which 60% involved alcohol or other drugs used by the person using violence, by the murderer, prior to the incident. So I think if we're looking at severity, that just says, actually, this is what severity looks like.
So, if the evidence is showing such an impact from substance use in perpetrators, why is there such a focus on victim survivors' substance use? And what's getting missed with this focus?
The example that I shared just before is a really good example of where sharing her use of substances, sharing the concerns that she had around her mental health, actually negatively impacted outcomes for her and her children. And so it really elevates for women, for mums, the concern around risk for their children. There's a lot of, I guess, stigma associated with substance use. There's also stigma associated with mental health challenges. And when we think about the expectations on mums as opposed to the expectations on dads, they're quite disproportionate. And so when we have mothers who are experiencing substance use challenges, even including prescription substances, the expectations and the focus, I guess, on them to keep their children safe is so much more pronounced than the expectations on the person using violence. And often that person is using substance use coercion in that relationship.
Agreed. And I think we often miscalculate the risk. So we focus the risk on what mum's doing because we haven't heard her or assessed her with genuine care, curiosity or capability. And so, as Monique was saying, we are meeting her with a moral view and kind of the moral paradigm of substance use rather than exploring what does substance use mean for her. How was she introduced to substances? Getting an understanding and actually doing a psychosocial assessment, supporting her being where she's at. Because we're doing women a disservice. We're actively doing a disservice to mothers and assessing her behaviour as the larger risk and missing what's actually going on behind the scenes. I guess when mothers disclose substance use as well, they're coming to us because they want to share their concerns, they want to share the risk, but then alongside with the stigma, that instigates a statutory response. So it can actually make things worse for the family rather than better, which is what we're all trying to do.
I think the main thing we're trying to do in this space is ensuring that if you ask for help with your substance use problems in the context of domestic violence, that in fact it doesn't close down your help seeking
Correct.
and create fear of the service response, but rather opens it up to help and support.
That's it.
Absolutely.
And I think that the challenges that we have within the sector at the moment is that we have a workforce or I guess a sector situation where it's quite siloed. So there are funding streams that direct us to where we need to be focusing, I guess, our energy. and they don't necessarily intersect as well as they could. And so then we have workforce who feel that it's not their role perhaps to engage with a mother who is disclosing her substance use or has quite a, like you said, a moral response without really understanding what the impacts might be for her, what the implications might be for her and for the children ultimately. So there's a real need to support and diversify the workforce in terms of understanding of substance use coercion, and the intersection with family violence.
I think if you stick within your railroad tracks and go, it's either about substance use or it's about violence, then you miss how is the substance use being used as part of the tactics of violence and abuse and coercive control. So that it isn't necessarily about substance use per se. It's about how is it being used in the context of domestic violence to weaponise, to exacerbate, to fabricate, to sabotage the victim survivor's use of substances, or how does he use it to enhance his control, to excuse his violence, or to justify or displace any attention to his violence. So it's missed when we divide up the sector.
Absolutely. And what we do see is women turned away from services because they are using substances. And so, like Cathy was saying, when someone's coming to us asking for help, how do we as a service system, irrespective of what our specialisation is, meet that client where they're at and provide tailored support to what they need rather than turning them away because of a moral standpoint or a lack in our own capability. So it's really important for us to upskill, but also to be advocating for the change that we want to see within our sector.
I feel like it's quite a big ask for the sector as well to expect everybody to be across such a range of things.
Yeah.
Like it is a lot.
I guess there's something there, isn't there, around leveraging off relationships and partnerships. We don't have to hold all of the information in our role, but who can we go to? Who can we ask for that support? Who can we connect with? Who can we partner with? Because ultimately, at the end of the day, it's the children and mums that we need to be supporting and supporting to enhance outcomes for them and safety.
What we really hear from frontline workers is that they want to be doing this sort of work. This is where they drive a lot of enthusiasm, learning, and passion for the roles that they do. The challenge really is being able to sustain it because it's incredibly resource intensive, and it only works if they can have legitimacy, authorization, and actual resources from senior managers, organizations, and even above that, I guess, the policy context as well.
Yeah, thanks for raising that. What have you learned from your previous research projects like Cody and Caring Dads about effective approaches to this challenge?
We learned a lot about collaboration. Clearly, there was an enormous amount of goodwill and commitment from two organisations that had been collaborating and were keen to collaborate further to look at this issue. What came clear over about 18 months was that in terms of the frontline workforce, it was absolutely exhausting, and that you can't do this work without some extra resource. That the goodwill of collaboration only lasts for a particular period of time, and while you've got those champions in those roles before they get burnt out and the churn. We've got to support with greater resource when you're dealing with complexity, either within one organisation or across organisations, to support the collaboration. And I think it's a nonsense to think that we can do this work with the complexity without addressing the resources that are involved. One of the things that we really found out from our data on Cody Caring Dads was in fact that the men who were involved in Caring Dads who had substance use had much longer, more severe problems in relation to both criminality and in relation to their use of substances and the violence that they were using.
And typically, correct me if I'm wrong, but the numbers for these programs were a lot smaller than the usual Caring Dads programs. So we had a fewer number of men coming through the Cody Caring Dads program who often demonstrated longer experiences of domestic and family violence and also drug and alcohol use, but they were also engaged or in contact with a wider number of children as well. So I think that's really important to think from the child's perspective, how many services are involved to support these fathers who are at the more higher end of the severity.
We have talked previously just about the challenge of staying in one lane, where AOD services focus on substance use and family violence services focus on safety. Can you paint a bit of a picture of what this looks like for a family who's trying to get help and what changes when services actually do work together?
I think in Victoria we've been impacted by having MARAM coming out, and that we're prescribed under MARAM to undertake collaborative practice. So we can use that to leverage off, whereas in the past we might have experienced barriers in regard to sharing information and collaborating. So that's great. We have an authorising environment where we kind of need to collaborate, because if we're not, we are doing our clients a disservice. And when we're not exploring the various facets and complexities, the psychosocial facets and complexities that families come to our service with, we are doing them a disservice if we can't at least collaborate with other experts as well, do warm referrals, etc. It sort of feels like old school social work in some ways, around how do we as a community support a family? What are the outcomes that we're all hopeful for, including what the family is hopeful for? How do we hold the family's needs and what they're looking for at front and centre, and therefore access the various resources that we need to? How do we collaborate with one another and network with our peers? I think that's the kind of key, but we need that authorising environment from our organisations and the policymakers and such to be able to do that work.
And I think if we don't have that, then what we have is we have families telling their story over and over again to different providers and really not getting to the crux of the problem. And ultimately, children miss out. Then their education attainment's impacted, their social attainment, their milestones are impacted. Just everything about that little person's life is impacted. And, we've missed an opportunity, I guess, to have that positive impact and supporting their safety and development. And so we really need to think about, well, how? And I think that's a great example, isn't it, around we might all come from different organisations that have, a bit of a different lens, but how do we arrive at the same end point? How do we arrive at we're all here with our different perspectives for the same outcome? So I think there's something there, and we, Odyssey and Kids First, I think did that quite well right from the outset. This is what we're here for. We have a shared understanding and a shared goal, and that helped then us to drive towards the same collaborative outcomes.
I think that having the Safe and Together training for both organisations created a shared language and a shared understanding of the dynamic of domestic and family violence that provided a very good foundation for the collaboration. In terms of the family work, it seems to me that these families are living with these issues intersecting and they're not separate. We have a very distorted service system response, which in fact then fragments them. And that's not the way these problems occur. I think our least developed area of work in the domestic and family violence space is in relation to whole of family work. How do you do whole of family work where in fact you look at each family member and the problems and the strengths that they bring to that family, and then how do you work the response which is safe and which is also effective? So it may be that when we say whole of family, we're not bringing everyone together like in a family therapy.
Absolutely.
But we are attending to everyone's problems, and there's a shared collaboration and information sharing that's understood by the family. No secrets, insofar as there's certain safety secrets that may need to be held, but in terms of the behaviours, that in fact that's a shared understanding of behaviours, particularly in the response team.
Yeah, fantastic. I love that, Cathy.
And what about from a research perspective? What does the evidence tell us about the impact of these separate or siloed services?
Well, I think there's many impacts on each family members if we're thinking through that, and some of it's already been covered. Firstly, for women victim survivors, when they're not receiving safe and seamless support, when they're trying to access safety and potentially fleeing domestic and family violence, then the risk and harms actually escalate. For children, victim survivors, it means they can potentially remain invisible within the service systems and no one's connecting with them. So we lose an opportunity, as Monique was saying, to actually provide early intervention. And I mean this from the child's perspective, and really disrupting those intergenerational cycles of trauma and violence that can occur in the future. And we haven't really touched upon this yet, but thinking through for the person who's using violence and substances as well. If services are siloed, that person using violence is remaining invisible within the service system, which means that a lot of the attention and focus is placed upon women victim survivors, and their responsibilities for change, but really not focusing on the person who's using that violence in the first place. And I think that's doing a real disservice to the whole family. Secondly, for those who are using violence and substances, when they are seeking supports, if services are siloed, then it increases the risk of collusion, which creates really poor outcomes from what we've seen from the research, but also practice as well.
And Van's point's really astute around how do we engage with the fathers who are using substance use coercion and what does that look like? And in the AOD, alcohol and other drug context, we work with a lot of fathers. So we have that opportunity to engage, and it's really important that we are sharing information, and we can do that in Victoria under the information sharing scheme, which has really changed the landscape on the work we do and how we hold men accountable and the fathers accountable for their parenting choices and their use of violence. So it's really important that we're working in that space.
Could you just explain what collusion means in that particular setting?
When we're colluding, it can be quite subtle. So that's when we're invited to, it's hard to describe the word without using the word, where we're invited to agree with the narrative that the person using violence is telling us. So it can be subtle things like nodding, agreeing, I guess confirming his narrative, not questioning or creating those invitations to explore the subtext around what he is presenting. So it's really quite dangerous as well, because we often get a lot of invitations to collude, which then is systemic collusion. If we're colluding with a person using violence as a system, that is extremely risky.
Even our first example from Monique would say, he would present to say,
yes,
I am the competent person in this family.
Absolutely.
I am the person who's doing all this looking after of this woman. And now you're asking me and suggesting that I may be abusing that position. How dare you?
Yeah.
So that there'll be an invitation to, in fact, to collude, to agree with his narrative that he is the stable person in the family, and not to investigate how he has set up and made the victim survivor look incompetent. And so I think that, as I say, it's subtle. I think that often too we are now being more thoughtful about listening to the person using violence and their own story of abuse, because often they come from families where in fact they have been the victims of abuse in their family of origin. I think that we just get clear that you can hear that story, but it mustn't stop the story not only of your harm to self, but the harm to others. So you have to be able to hold the conversation for him of the harm to himself as well as the harm he's doing to others.
Correct.
Absolutely. Because what we know is that there are plenty of people that have had their own experience of abuse and harm as children that don't go on to abuse and harm their families. So we really do need to be really mindful when we're hearing the storytelling that a lot of men using violence will share with us, that there is a context to that, and perhaps there's a reason why he's sharing that story with us as well.
And I think from a practice perspective, you can sort of, and this might sound a bit woo-woo, but you can sort of feel there's something uncomfortable about it. Like, what just happened there? I can't quite put my finger on it. And so while we should be collaborating with other services, that when we're feeling those feelings, and we need to kind of take that to your line manager, talk to someone else about it, explain the situation, that something doesn't feel right, and engage your professional skepticism. I think sometimes we don't do that enough. We're like, oh, there's just not something, something's not sitting right with me, and talk to someone about it. I think that's the key. If there's a family violence advisors or a family violence specialist in your organisation, it's always important to share that, because again, it can be quite risky if we are agreeing to his narrative.
It can be quite difficult when you end up in a situation where you're using something like the MARAM and you've got to go through a bunch of check boxes and everything's ticking okay, but you're still not quite, it's not quite right.
Exactly.
Yeah. Looking ahead, what sort of changes would make the biggest difference for families experiencing substance use coercion, and what's the practical shift you would like to see from policymakers, decision makers, fellow practitioners to make this happen?
Like we've had, I guess, the Royal Commission into Family Violence and significant reform, I would like to see something similar within the alcohol and other drug space, the substance use space, because with the authorisation of the recommendations, we have been able to see significant change, that this is part of all of our work. That family violence has become part of everybody's work and responsibility. I would love to see that shift within the alcohol and other drug space, because when we think about substance use, we always have the kind of stereotypes. We're missing so much if we just stick to the stereotype and if we're not working in an integrated way. So I'd love to see development in capability within alcohol and other drug space, within substance use coercion, and understanding that, and for the systems and the sectors to work in an integrated manner. I think that is the key. We've spoken about staying in our lanes and what that looks like, and it can be sort of almost a competitive environment. How do we move away from the competition and actually focus on developing a system that is tailored and targeted to what the community need?
So it kind of requires, if we're thinking from a Victorian perspective, looking at the funding models in terms of all of Victorians, doesn't it? So that we're not just, I think when we look at certain areas and funding those certain areas, then that really creates those silos. And then it really goes against what you were saying, Cathy, around that whole of family approach, and really that whole, essentially it's a whole person approach to an extent as well. So if we can look at what that funding sort of environment looks like and what that governing environment looks like, then we can then filter down into creating a more fluid, collaborative response for families. So it really does need to start at the top.
Yes.
We can do as much as we can try and do, pushing it up from the bottom, like Van and Cathy were talking about before in terms of what was observed through Cody, was that it's just not sustainable when we don't have the authorising environment to support that work.
And I couldn't agree more with the both of you right there, because what we're really seeing is that it's frontline practitioners or service organisations who are bearing a lot of the responsibility to constantly be innovating, piloting programs, trying to collaborate with researchers like ourselves to meet the needs that they see amongst families. But that's incredibly resource intensive and exhausting. And that part of that contributes to the burnout as well, when these great programs are not being socialized or sustained, beyond, the initial pilot stage. So really what I would like to see is to really start seeing a lot of leadership, a lot of brave conversations happening on that leadership level, that governance level, because at this point in time, our governance structures have really siloed off each of these issues. And what we know is drug and alcohol isn't just exclusively a health issue, and yet it really does sit within the health department and their funding. Right? And same thing with family violence. It's often seen as a social issue and expanding to a health legal context, but it's not only a social welfare issue as well. So what I would like to see is a lot more champions coming across in that senior management level or government level, coming across to have these really tricky conversations about what it means when families are experiencing these intersecting issues of family violence and drug and alcohol, and how are we going to create a funding structure that actually supports these families in the ways that they need, and also looking at, or can we actually create integrated programs that can address both of these issues at the same time? Because from the research we've seen, any integrated programs that address both family violence and drug and alcohol simply isn't being sustained beyond the pilot phase.
Correct.
And so I think I'd like to just put my little research hat on to say, I actually think we're not clear yet about the models that are most effective in this space because we haven't had the chance to do substantial evaluation in this area. If something only gets to pilot phase, like say Cody, you've only got very small numbers. Like we've had a go, but actually the numbers are too small to really say this is a model that works. And when you looked internationally, there were 9 programs, weren't there, that were peer reviewed, of which by the end of your scoping review, half of them had already finished and weren't sustained. So that I think we're not clear either for victim survivors or for working with a person using violence or for children about what are the best models. You know, should it be that where you've got working with, you know, men's behaviour change, you need an alcohol and other drug specialist in that space, or should they be jointly facilitated? Should it be secondary consultation? Should it be that you just support the collaboration? There are different models that we could use in this space, but we haven't had the opportunity to really look at the data or to evaluate to say this is the model that potentially works the best. They do need to fund programs for more than 1 year. You know, you need at least 5 years to be able to evaluate a program over time because, you know, the first 18 months at least are about getting the model in place and training up your practitioners so that I think, and you need some version of the Safe and Together model to provide a foundation that's shared in relation to understanding domestic and family violence. But then from there are different ways in which they could fund different models that you could then evaluate against each other. You know, we could look at if you've got 2 services and you fund the collaboration, you know, with a collaboration coordinator and case manager, is that the best model? Or is it that, in fact, we model the Caring Dads program or men's behaviour change program with a drug and alcohol specialist? Or when we're looking at the victim survivors, what's the best model? Is it to have generic workers who are able to work across both substance use and domestic violence and understand that complexity? Or is it better to hold on to specialisation but fund the collaboration? So I think we're just unclear. And as it comes to children, you know, we know which are the children that are coming into care, those where you've got not just domestic violence, but where you've got domestic violence and substance use or domestic violence, substance use and mental health. So we have to think about the children and build up from there about the sort of model that we're going to say is able to be sustained and is effective.
So we have talked about how substance use coercion affects victim survivors directly, but what are we seeing and learning about the impact on the children?
It's quite interesting. So when I was working as a specialist family violence advisor in the alcohol and other drug sector, I worked alongside an adolescent community program. And so they would work with children and young people who had substance use issues. And substance use coercion isn't just something that we see in adults. So it's quite a high prevalence for children as well, where there's family violence present, substance use present, and the introduction to substances is by a father, for example. So we often miss that key there around what does the support look like? had we had better integration of services, we could actually support children and young people properly, that we could intervene before we're at the point now where we're looking at detox and rehabilitation inpatient stays for the young people. So thinking beyond what we're seeing as well, and exploring, having the conversations with children and young people about their introduction to substances. What might we need to explore in regard to significant risk? Because there are particular substances that we would explore in the AOD sector around, I'm worried about sexual abuse risk because of the particular nature of a central nervous system depressant. So I'm probably getting into the specifics of it too much, but we need to kind of take a step back and think about how are children and young people impacted, how are they targeted as well, and are we exploring their situation, their experience with curiosity? Are we assessing the risk effectively with children and young people, or are we just working with the adult victim survivor and thinking about the children as kind of an accessory? Are we actually engaging with children? And I think a lot of services aren't. Or, we hear we're not funded to work with children, we don't work with children, we're an adult service. So how do we actually work with the whole of family is going to be an important one, like Cathy is saying. We need to do a lot better in the service system and I guess the authorisation space.
So there's something there around children's exposure to substance use and substance use coercion, what then leads on to for them. So is there normalising of the behaviour? Are they impacted by the behaviour because now, they're having to kind of look after themselves because dad maybe is really, affected by substances. So now I've got to look after myself and my younger siblings. So they're really parentified. There's just so many impacts for children when there's substance use, excessive substance use, but also substance use coercion, where perhaps they're seeing dad engaging in these behaviours towards mum. And so what does that mean for me as a child? What potentially could dad then go on and, do to me? Or, there's a lot of unsafe experiences for children and young people that we're not necessarily aware of if we don't engage with those children and young people and really seek to understand what those experiences are and how we can perhaps support them through those experiences.
It seems to me that one of the biggest gaps in the whole public health approach, which is looking at primary prevention, secondary prevention and tertiary prevention, so looking at how do you prevent it from starting, how do you support and intervene where you've got children and young people at risk, and how do you respond or do the healing and recovery once it's all happened. The biggest gap is in that secondary prevention. We're not getting in early enough. Every report you read says we need to intervene earlier. Well, let's intervene earlier, but where have we got the least resources coming? No resources in this saying, actually, let's not wait till we've got to the crisis, which is the tertiary prevention. We know that children who are living with domestic violence and substance use are at risk in all sorts of ways, both right at the moment but into the future, in terms of their health, their well-being and intergenerational abuse. So we need to be saying loud and clear that secondary prevention, looking at where there's children living with domestic and family violence and substance use, are children in need of a response, and we don't want to wait till a crisis.
Yes, beautiful.
Yeah, it's an economic argument for that as well.
A very strong economic argument for this.
Absolutely.
So what are some of the practical steps to foster this collaborative effort?
What I encourage folk to do is get to know, firstly, your local services. So it is about just making a phone call and saying, hey, I'm Emma from Odyssey. I work around the corner from you. I would love to connect. No doubt we have mutual clients, or at least we're working on some similar cases. It would be really good to connect in. It's those kind of old school practices that I think we lost in COVID, where we used to often go to each other's team meetings and present, have a fruit platter and have a conversation. But just connecting with people is really, really important.
And I think there's so many opportunities for co-location. where you can work with another organisation to place yourself within that organisation and vice versa, which then has a ripple effect, not just for that particular practitioner, but for the whole organisation, where they're interacting with someone that perhaps does have some more specialised skills within the AOD or the family violence sector that can support and nurture capacity building within your particular area. So there's some real richness that can come from those sort of co-location opportunities. Things like get along to conferences, go to network meetings, really get to understand what's happening out there, what other organisations and other practitioners are coming up against as well, because out of those challenges often comes some really great opportunities. So it's about seeking those opportunities for collaboration.
And I think all these collaborative activities are wonderful, and it's what brings a lot of enthusiasm and satisfaction for practitioners, thinking about my practitioner days, but it can't just be an add-on to your normal job as well. And that's a part of the authorising environment where, we have a lot of organisations or government policies that endorse this way of working, but it seems to be an add-on because there's always the focus on meeting your core business first, and then you can do these things. When the reality is these are full-time workers with 9-to-5 jobs, and they want to go home at the end of the day. So these sort of collaborative processes really need to be a core part of one's responsibilities and not just seen as an additional extracurricular activity.
And because ultimately they should then support those outcomes within the core business. So, yeah, absolutely.
Because what you're saying is there's an efficiency by attending to process, which is an efficiency which is about attending to relationship. If you work in Aboriginal organisations, they actually spend a lot of time on relationship and trust, and that we can't work together without trust. That means you've got to take it beyond the task, whether that's about the family or finding housing or whatever, to spending some time on relationship building.
Yes. So you work in a space where gender-biased attitudes about substance use are still prevalent. Can you talk about how these attitudes shape responses, particularly in different ways we tend to view and respond to mothers versus fathers who use substances?
So in the family services sector, predominantly it's mums that are referred through. And so they are the primary client with their children. And so how that sort of plays out then is that they are seen as responsible in terms of the parenting role. And when it comes to substance use, and if we don't have a really good understanding of what that substance use looks like, what the real impact is on the children, we go in with a lens of any substance is bad and any substance has a negative impact on parenting and on the children. And so then what that looks like is that we will go in with really high expectations of mum to address her substance use, which can be quite harsh. And the children are kind of invisible there, even though it's through a lens of we need to protect the children. So really need to think about and look at how we're viewing substance use and how we're viewing mums and women in the context of substance use, thinking through a harm minimisation lens, but also like really trying to understand, well, what is the substance use about? When is she using those substances? What is the impact of this? What are the substances?
Correct.
Because there are varying, substances that mums might be engaging in, and we need to understand so much about the context and the drivers of that substance use so that we can really get into working with her around whatever it is that she's needing that support with.
Because the gender double standards exist.
Yes.
We have mums up here, dads are here in terms of the gender double standards, which are exacerbated when there's substance use as well. So it is, as you've articulated, that already exists. And so with the case that you were talking about at the start, the kids were placed with dad, weren't they, for a period of time? Yeah. And so, again, the assessment of risk is incorrect, and the children are now at more risk because they've been placed with the person using violence, because we've held mum up to a different level and a higher standard, and also stigmatised her for using substances and blamed her for something that is not of her doing.
And increased his power.
Absolutely.
And
so
ignored the children's experience and all of that. Sorry,
No, but the system has increased his power by him having children.
And that's what I was thinking when we talk about substance use coercion. It doesn't apply to all families.
No.
We recognise that substance use exists on a spectrum,
Absolutely.
anything from non-problematic, enjoyable substance use to, the other end of the spectrum. But what we're talking about here when it comes to substance use coercion is thinking through how is a person who's using violence exploiting the victim survivor's substance use to extend their own power and control. So the example I could think of is, if a woman is choosing to use illicit substances on a night out, then there's no harm to self or others in this context, that's fine. But when she returns home, if a family member is taking that substance use as a way to undermine her, to call her a bad mother, to, use that as evidence to child protection and so on, I think that's really a clear sign to me that substance use coercion is occurring. So the focus here with this concept is really thinking through how's the person who's using violence weaponizing a victim survivor's substance use.
Absolutely. And I think if we think about First Nations families as well, plus in terms of the stigma and the judgment for First Nations families as well in that space, which is undeniable.
What about the issue of information sharing? How can this be managed effectively while still protecting safety and privacy?
This is such a big issue, and in Victoria taken on by the Family Violence Royal Commission, because they realised at the heart of one of the problems was the ways in which privacy was being allowed to trump safety. It was a clear message to say, as long as you allow the violence and abuse to remain secret and only held by the police, say, or the health practitioner, then you put everybody at risk. And so it was one of the clearest findings and recommendations from the Family Violence Royal Commission, and one that was acted on early, was to say we cannot allow this to continue to happen, that it's a violation. On the other hand, it can't be used either to say that victim survivors have to have all their issues exposed. It's about looking at the person using violence and the way in which that information is shared, not all the information about the victim survivors and not necessarily all information about the children either in relation to the person using violence. Some conversations for victim survivors must be private and held safely. And you can hear the Brittany Higgins situation where they're wanting to use her mental health against her. That was a clear example of the distortion and abuse that can occur around information sharing, and which was being called out, but only after the fact.
I think it's only one mechanism, really, if we think about it, information sharing, but it has to align with strong feedback loops that's within a closely connected team, but also making sure that those professionals who are engaging with information sharing are domestic and family violence informed to understand the risk and the safety issues that are posed when we're sharing that sort of information as well. So it's not necessarily just one strategy that's going to enable safe and seamless supports, but a whole range of mechanisms that have to be put in place and working well to provide a systemic response to these two issues.
Great point. I think ultimately it is about, again, as you were talking about, Cathy, we're pivoting to the person who's using violence, which is language from the Safe and Together model as well. But we have often been so focused on what's the victim survivor doing, what's she doing from a deficit and not a strengths-based approach, that we're ignoring what the person using violence is up to. How does information sharing, collaborative practice, connecting, how does that support us to understand what the person using violence behaviour and then the subsequent impact? That helps us then understand her behaviour as well. Because from a harm reduction perspective, and similarly to when we're doing a family violence risk assessment, we want to ask, what is she already doing to reduce harm to the children if she is using substances, through choice. That's really important. You can do family-focused, child-focused harm reduction work within the alcohol and other drug space. It's not overly complex. So I think if nothing else for the kind of practitioners that are starting to engage in this work, it is exploring what does harm reduction mean and what do those conversations look like with victim survivors, which can absolutely navigate substance use coercion as well. We can hold this complexity. It's not beyond us. We can definitely do it.
Thanks to our wonderful guests for sharing their expertise and insights on this critical issue. Having practitioners and researchers in conversation together really highlights what we've heard throughout the episode. That addressing substance use coercion in domestic violence requires exactly this kind of collaboration across the sector. There's more to explore. These same guests expand on this discussion in the Work Up Queensland Spark webinar series, so be sure to check out that recording for additional insights. The key messages are clear. We need different parts of the system working together, not in silos. We need sustained, long-term funding that allows us to rigorously evaluate what interventions actually work. And at the heart of it all, we must keep victim survivor and family safety central while holding perpetrators accountable for their actions. Substance use coercion is a tactic of control that often remains hidden. But as we've heard today, recognising it and responding effectively can be life-changing and even life-saving for those experiencing abuse. If today's conversation has raised any issues for you, please seek support. Contact information is included in our show notes. Thank you for listening to CEVAW Conversations. This podcast is recorded on the lands of the Wurundjeri people of the Kulin Nation. We pay our respects to their elders past and present and acknowledge their continuing deep connection to country. We also recognise the many diverse traditional custodians across Australia and extend our respect to all Aboriginal, Torres Strait Islander and other Indigenous peoples around the world. This podcast was produced by Sean Human and Greta Robinstone for the ARC Centre of Excellence for the Elimination of Violence Against Women.